So we're going to look here at the eye, which is going to allow us to have our visual sensation. So we look at the eye and the visual pathways that allow us to perceive things in our external environment visually. So we'll start with looking at the external anatomy of the eye. And when we look at the external anatomy of the eye, we start with the papilla, the eyelids, in which we have a superior and an inferior. Where they junction together, we get the commissures. To the medial side, we have the medial commissure. To the lateral side, we have the lateral commissure. On the medial commissure, we get the lacrimal carnicle, which is going to lead to the exiting of the lacrimal duct, or the entrance to the lacrimal duct, with the lacrimal gland being to the lateral superior edge of the eye, and lacrimal secretions flooding from the lateral superior to the medial inferior. We get protective projections of the eyebrow as well as the eyelash. We have the iris, which is going to control the amount of light that will be able to enter into the eye, and the entry point being the pupil. Continue looking at the external anatomy, even though it looks like we're looking at the internal anatomy. We start with the muscles that are going to allow us to have an open or closed eye, the orbicularis oculi muscles. We then get to the structures that will support the protection of the eye, which includes the papillary, the eyelids, with the eyelashes and eyebrows. On the papillary, we have glandular structures. These glandular structures are going to allow for immune protection, as well as secretions such as lacrimal secretions that will keep the external structures of the eye from becoming desiccated. We have external structures such as the cornea and the sclera. We will see the iris and the pupil externally. Just internal to the pupil, we get the lens. Controlling the motion of the eye are the extraocular muscles, which include the inferior oblique, the superior oblique, the superior rectus, the inferior rectus, the medial rectus, and the lateral rectus. And then we have the muscles that's going to assist or allow for the opening of the eye, the levator papillar, and we have a superior and an inferior muscle there as well. Working internally, we start with recognition of having two distinctly referred to as cavities or chambers within the eye itself. We have an anterior cavity and we have a posterior cavity. The anterior cavity is going to be surrounded by the structures that we have previously seen, the cornea, the iris, and the lens. The lens is held in place by the ciliary muscles and the suspensory or suspensory ligaments, the fibrous lens. This area here is going to tense the lens to allow for changes in curvature of the lens to allow for focusing of light onto the fovea centralis. In the anterior cavity, we have what's referred to as the anterior and posterior chamber. The anterior and posterior chamber are filled with aqueous humor, whereas the posterior vitreous chamber is filled with vitreous humor. The aqueous humor has a circulatory pathway that starts with generation within the ciliary processes of the ciliary muscles within the eye. It will then circulate through the posterior chamber into the anterior chamber. It will then be collected within the sclera venous sinus. The sclera vena sinus will then drain into the ciliary vein. The ciliary vein is contained within the sclera itself and rides just superficial to the sclera on the external surface of the eye. The movement of fluid through the anterior cavity is one of two eye diseases that can be developed within the anterior aspect of the eye. One is dealing with fluid pressure itself. The other one is dealing with the opaqueness of the cornea due to ultraviolet light exposure. And we'll take a look at each one of those when we meet together. As we work further into the eye itself, we start with all of our structures that we've seen so far, such as the cornea, the pupil, the lens, the suspensory ligaments, our chambers, our extraocular muscles. Coming off of the iris muscles and linked with the ciliary body is structures known as the ora serrata. The ora serrata is going to link with the ciliary body and the suspensory ligaments that lead to changes in the diameter of the pupil based off of the need to accommodate for distance of vision. Within the iris itself, we have two actual layers of muscle. You can see it a little bit more clear on this image than you could before. We have a radiating layer of muscle and a circular layer of muscle. Those two layers of muscles will allow for the dilatation and constriction of the pupil based off of sympathetic and parasympathetic stimulus off of the ocular motor nerve. We then get to the tissue that's going to be responsible for reception of visual information, the retina and its support tissue, the choroid or the choroid plexus. Within the retina, there are two areas of importance, the fovea centralis. The fovea centralis will be the center point of focus of light from the lens. Along with the neural tissue, because it's neural tissue, we have to have a constant state of perfusion. That's going to come from the blood vessels. And the blood vessels will break out into the capillaries, with the largest density of capillaries being at the macula lacteal region, which is going to support the fovea centralis, which is going to have the highest density of cone receptors within the retina itself. Now, in order to ensure that the lens is angled at the correct spot, we have a secondary ligamental structure coming away from the suspensory mechanism known as the haloid canal. This haloid canal supports the lens in an anterior-posterior positioning, whereas the suspensory ligaments are going to suspend the lens in a 360-degree pattern to the anterior side of the eye. So let's look at the anatomy of the retina, and the anatomy of the retina is set up in such a way that the receptor cells are actually the deepest cells within the retina. And we have a host of different types of cells coming into play here. The host of different types of cells include the photoreceptors, the rods and the cones. These rods and cones will link onto the bipolar cells, which include the horizontals and the midget bipolar cells. And there are different types of midget bipolar cells. There is the flat midget and the invaginating midget bipolar cells. We also have the rod bipolar cells and the diffuse bipolar cells. All of these bipolar cells will synapse onto the amacrine, parasol, and midget ganglion cells. These ganglion cells is what's going to form the neurons of the optic nerve. If we look at the anatomy of the retina, with the photoreceptors, we have two distinct types of photoreceptors. We have rod photoreceptors and we have cone photoreceptors. The rod and cone photoreceptors are made up of the receptor cell itself and then the outer segmental receptor area made up of folds in the case of the cones and discs in the case of the rods. And these areas contain a pigment that is going to become excited based off of exposure to distinct wavelengths of light. In the case of the cones, we get peak excitation on three distinct wavelengths: the blue, the green, and the red conal wavelengths, also referred to as the short wave, the medium wave, and the long wave. Within this bit of excitation, notice how the peaks of the red and the green are very close to each other. Because these peaks are very close to each other, small mutations within the pigment responsible for the excitation can lead to less than peak excitation at those wavelengths. If we have lower than optimal excitation at peak wavelengths, we end up having color blindness. And because the reds and the greens are so close to each other, it's why red-green color blindness is very interlinked with each other in terms of color blindness. So you don't really hear about blue-red color blindness or blue-green color blindness. It's usually red-green color blindness. Now, what's really cool is that if we give somebody who happens to be red-green colorblind polarized lenses to cut out wavelengths in between the two peak zones, they can start to see colors in the green and red color ranges, just not at the level of acuity that a normal person would see. The rods, on the other hand, tend to be ubiquitous, which means that they have a range that goes across the spectrum of light wave, where their peak happens to be at 490 nanometers of wavelength of light, which puts us down into the blue end of the rainbow of colors. We also use different types of protein pigment that become excited in the rods relative to the cones. Rods use the pigment rhodopsin, whereas cones use the pigment photopsin or idaopsin. Both of these opsins need metabolites in order to function correctly, in particular vitamin A to function correctly. And the principal form of vitamin A that will be metabolized is the beta carotene form of vitamin A, which is why you need to have a set amount of vitamin A or beta carotene in your diet in order to have normal visual responses. If we look at the map of the retina, we notice two distinct things. The greatest density of cones will be at and within 15 degrees of the fovea centralis, with a constant low density throughout the remainder of the retina. At about 70 degrees away from the fovea in a 360-degree pattern, we lose most of the cones in terms of their density. And that simply has to deal with the loss of reception within the visual field at that point due to the physics of light travel. On the other hand, rods have their lowest density at the fovea and their highest densities beginning at about 20 degrees outside of the fovea. And then they slowly taper out as they head out towards the outer edges of the retina. Now, these rods will continue all the way out and around the internal structure of the retina, unlike the cones where we happen to have a tapering off as we head to those most lateral aspects. And what this means is that based off of our ability to perceive color, we will have the greatest perception of color and our greatest level of visual acuity with light striking at the fovea, and it will drop out as we head laterally away from the fovea in a 360-degree pattern. Now notice there's a spot where there are no photoreceptors. That is the anatomical blind spot. The anatomical blind spot is the area where there are no receptors for vision. There is no receptors for light. That is where the optic disc will be, and that is the area where the optic nerve will start.